I am your host today. My name is Erin Fazer, and I'm the Director of Education here at Naraxon USA. And we have invited Cassie Butts. Cassie, can you switch to the next slide?
Yep, there I am.
There we go. So this is Cassie. Cassie, to get us started, can you give us a little bit of information on your background and some information on what your current role is?
Yeah, absolutely. So thank you everyone for joining us today. Like Erin said, I'm Cassie. I'm a physical therapist out in Southern California. I studied physical therapy at USC, University of Southern California, and then worked at an outpatient sports physical therapy center for 10 years before starting 3 Planes. So in that time, I got my specialty in orthopedics, and then I also went through the Gray Institute's Fellowship of Applied Functional Science before starting 3 Planes a few years ago.
Can you also share a little bit about how you got started with Naraxon?
Yeah, absolutely. So both my husband and I are physical therapists and working in sports orthopedic clinics. And we saw this gap in our ability to really assess movement for higher level athletes and clients and patients, especially those who needed to run or who were wanting to get back into sports of any kind. And so we started looking for technology to help us. And we came across Naraxon's mobile system and mobile unit. And we saw this great opportunity to be able to provide these running analysis, return to sport decisions, throwing assessments, all of these high level tools that clinics need. We saw an ability to be able to provide that service for clinics throughout Southern California. So we've had the Naraxon mobile unit for a little over 2 years now, and we're able to go to different clinics and help with their patients or bring in outside people as well.
And you're, I think, going to take a little bit of time today to show us what that looks like before we wrap up. But
Yes,
to get started,
absolutely.
do you want to go ahead and share what you'll be speaking on today and then kind of get started with the presentation itself?
Yeah, absolutely. So today we're going to be going over a return to sport test. So I'm going to do that by sharing a patient case with you guys, and then I'll go over how I'm able to quantify data from that athlete to help make that really important decision of are they ready to go back to sport or not. And then after that, I'll show you what equipment I have and kind of how my business model works a little bit, and then we'll leave plenty of time for questions at the end. So today I'm going to be introducing you to a 17-year-old female high school and club soccer player. So about 11 months prior to me meeting her, she had sustained a non-contact ACL tear. So she was in the middle of a game and just run and cut, and down she went, tore her ACL. About a month after the injury, so about 9.5 months prior to me seeing her, she got a reconstruction with her own quad tendon. So her rehab had been a little bit slower than we typically expect, but even so, her physical therapist reported that she had had really good compliance throughout the entire process, and it just went a little slower for her for whatever reason. She was currently still seeing a physical therapist 1 time a week, and then she was also seeing a sports performance coach 1 to 2 times a week when I saw her. She reported that her left leg was at 100% strength, so it was exactly where she wanted it to be to go back to sport. However, she still felt that she was lacking about 30 to 40% when it comes to her endurance, so both her cardiovascular and her muscular endurance, as well as her power needing to go forward. So her goal for today's test was to be cleared to return to her team. She really wanted to be able to go back to practice and start that transition from practice back to playing. So that was her goal for this test today. After speaking with the patient and figuring out kind of what they've been through, where they are, what their goals are, I always start with strength. So I utilize a handheld dynamometer, you can see the picture there on the right, to test their strength. So for an ACL return to soccer athlete, I test glute max, glute med, quad, hamstring, and calf. So I test most of those using that dynamometer, and to make it easier for myself, I tie a belt through the dynamometer and attach it to the table. So the patient will do an isometric hold against the dynamometer, and I just have to hold it in place It also helps them feel that they can really push against it, especially if I have someone that's quite a bit bigger than me. And then in that picture, you can see for glute med, I actually wrap the belt around his knees. And then I just have to hold it in place for them. When we're looking at strength, the two big things that we're looking for are symmetry as well as sufficiency. So when I say symmetry, it's not just right versus left leg that we want to be symmetrical, but we want the musculature within the limb to be the same. So that glute max needs to be roughly the same as the quad in terms of strength. When the body has an imbalance in the system, that typically is when we see injuries happen. We're also looking for sufficiency. Does the patient have enough strength to perform their desired activity at the desired level? So to do that, I utilize expected norms that were developed based on pain-free participants. So Dr. Powers in 2009 took people who had no knee pain and saw how strong their glute maxes and glute meds were, and then developed a number based on their height and their weight that we aim for. And then we also take that number, and of course we want that to be the same for the quads. And so that's how we determine if the patient is strong enough. By doing this, we're able to produce results that make a little bit more sense to the patient. So telling them they have 300 newtons on their quad doesn't mean a whole lot to them, but saying that they're 100% strength means a lot to them. So here are her results. So her glute max or hip extension was nearly 100%. So it's looking really good. However, as you can see, her left glute max was about 10% less than her right glute max. So this meant for her normal, she still needed to get a little bit stronger in that glute max. For her glute med or hip abduction values, you can see that she had moderate strength deficiencies on both sides. So that glute med is incredibly important with anyone who ever wants to be on one leg, which is pretty much the entirety of a soccer game. So we're definitely going to still work on that glute med strength. These bottom two values are that symmetry I was talking about. So we want her left hip extension or glute max to be equal to her knee extension or quad. So she's right at 0.9, so right where we want her to be. We accept anything between 0.8 and 1.2. Remember that left hip extension was about 10% weaker than the right, which means that her left quad is still roughly 10% weaker than her right quad. So still a little bit of work to go there. I didn't include her hamstring or calf values because they were right where we wanted them to be. The takeaway from her strength was that she still needed to do a little bit of work with her glute max and quad strength, and glute med bilaterally needed to be a primary focus moving forward. So after strength testing, I allow the athlete to do whatever kind of warm-up they would normally do. Once they're nice and warm, that's when we start to strap them up and hook them up with the sensors. So for a return to sports soccer athlete, I'll go over the equipment I have later, but for her, we did the spine, pelvis, and both legs through the feet, excuse me. You can see this is a pretty typical facility that I work in. So I don't have a huge problem with magnetic interference for the sensors, which is really lucky. I'm also able to, most of my athletes are also able to achieve the upright standing posture very easily. So that's what I utilize. I cue them to stand upright, of course, make sure that those feet are forward and straight under their hip. And I tell them that they need to be straight but comfortable. I explain to them why I'm doing what I'm doing and why they need to be in that posture. You know, we're looking for their zeros. And just that knowledge typically helps them achieve the posture and hold it because they want good values. To ensure the quality of the calibration, what I do is I have the patient, I cue them to march both knees up to about hip height. And I look at the avatar on the screen, look at what they're doing and say, oh, that looks just how I want it to look. The other thing that I do is I'll have them stand with their feet together. I believe that hip adduction and abduction are incredibly important values to discern with these tests. So if they're standing with their feet together and the avatar has their feet together and they're not crossed or bending weird at the knee, then I'm feeling really good about all of my values. The next thing I test is running. And so in this facility, the treadmill is actually in a different room. So what I did was I had her just do 3 huge laps around the turf and recorded that data. Didn't even bother with the cameras for running, because then I'll just run the running report in the Naraxon system and get all the data that I want. So if you're unfamiliar with the running report, the first part of it breaks down the athlete's stride. And so what I'm really looking for is the amount of time that she spends in swing versus stance. So we're looking for that to be about 60% of the time to be in swing and about 40% of the time in stance. And of course, going back to symmetry, we want her left leg to be roughly the same as her right. So she was right on there. The next part of the report breaks down the movement at individual joints in a specific plane. So what I've included here is her knee flexion and extension graph, as well as her ankle dorsiflexion and plantar flexion graphs. So if you're unfamiliar with these, what you're looking at, that top graph is her knee flexion and extension. It starts at initial contact and then goes through the entire stride to the next stride. That middle vertical line is toe off. So everything to the left of that vertical line is stance, and everything to the right is swing. And then it overlaps right versus left. So the big thing that I'm looking for here, again, is symmetry. So you can see how her 2 graphs overlap almost perfectly. So what that says is that she feels comfortable loading that left leg to the same degree as the right leg. One of the biggest hurdles for people coming off of an ACL injury is feeling comfortable and trusting that injured limb to bend again. So doing a simple single leg squat for them is really difficult at first. And so I want to ensure that they're comfortable loading into that reconstructed limb to the same degree as the other side. What this loading tells me is that they are able to recruit the musculature around their knee when they do a high level activity like running. So when those muscles are activated and working for them, that's going to protect their knee better. Furthermore, the ACL is most vulnerable between 0 and 30 degrees of knee flexion. So we want to make sure that that patient is comfortable flexing beyond that. Otherwise, they're going to spend their entire time in a vulnerable position. This athlete is a 4-foot runner. And so we expect that knee flexion to be between 25 and 35 degrees. And I think she's roughly peaks just above 30. If she were a heel striker, we'd be looking closer to 35 to 40 degrees of knee flexion for what we're kind of looking at. So after running, we get into the meat of what we're doing. So we're going to do our sport-specific movement screen. So when you're developing one of these, you want to remember, you want to think about how you're going to measure movement. You want to be able to look for symmetry, and you want to be able to put a number to a complex movement. This helps you develop repeatable data that you can track from time period to time period, and it also makes things consistent from one athlete to the next in terms of what their overall score ends up being. You of course need to address the needs of the sport. So for soccer, it's a very multi-directional sport. They're on one leg, they're on 2 legs, they're jumping, they're running, they're cutting. So we use 6 movements to cover all of these skills, if you will. And then each movement has an individual score, and then we add them all together to make a composite score to give the athlete, and that helps us determine if they're ready to go or not. I'm not going to go over all 6 movements. That's a whole weekend course. So we're just going to go over the step down. I think step downs are one of the easiest tools that we have to be able to see where a patient is. So the way I do step downs is I'll have the athlete on a pretty high box. So you can see she's actually on a 10-inch plyometric box. And that's the standard size that I use. I'll go down a little bit if the athlete's under, say, 5'2", or I'll go up. I'll make them work a little harder if they're about 6'2", 6'3", or taller than that. I have her do 10 step downs, just kind of kissing the floor with her heel and coming back up. So not fully putting that weight onto the other side. And I'll have them do 10 of those, and then I score the 10th one. My snapshot in time is always going to be at max knee flexion. So what's nice about having these sensors on her is I'm able to very easily and without debate determine where max knee flexion is. So then you can repeat that over time as well. And at that point in time, we want to break the movement into measurable components. So for a step down, we break it into 4 components: hip stability, pelvic stability, trunk stability, and hip strategy. Each of those components is then given a score of 0, 1, or 2. So 2 is no deficit, 1 is mild deficit, and then 0 is a significant deficit. So the first one is hip stability. So that's those numbers on the right. So hip stability could also be called knee valgus. It's when that knee caves in. And was there something, Erin? Sorry, I just heard noise. Okay. So knee valgus is broken into 2 components: hip adduction and hip internal rotation. So we're able to get those specific values there on the right. So when you stand on one leg, you have to shift your weight over to that side. So you're going to automatically be in about 10 degrees of hip adduction, which is a negative number. So it's -10 just standing on one leg. So we then allow for about 5 degrees of grace. So 10 to 15 degrees of hip adduction would be a 2, no deficit. 15 to 20 is a 1, and then greater than 20 would be a 0. So she's at 27.7, so she's already at a 0. Then looking at hip rotation, the patient should be roughly 0. So we allow for 5 degrees of grace. So 0 to 5, we won't minus any additional points. 5 to 10, we minus 1 more point. And greater than 10, we would minus 2 points. We don't give negative numbers, so if they're already at 0, that's just what they're at. But let's say that the patient was at -18 hip abduction and -7 of rotation. That would also be a 0. The next one we look at is pelvic stability. So this could also be called a pelvic drop or a hip hike. In the program, it's called pelvic obliquity. So this one's really easy. We have a very number to look at. We want that to be neutral. So 0 to 5 is a 2, 5 to 10 is a 1, and greater than 10 would be a 0. So she got a 0 on pelvic obliquity as well. Trunk stability, I didn't include on here because it got a little bit messy, but it's looking at that frontal view of her step down and looking for a side bend or side lean to the right or to the left. So she was about 4 degrees, and 0 to 5 is a 2, 5 to 10 is a 1, and greater than 10 is a 0. So she got a 2 on trunk stability. Hip strategy is the most kind of complex one. That's that picture on the left. So there's 3 components that go into determining the hip strategy score. The first one is the thigh angle. So we want that thigh angle to be 30 degrees or less from the horizon. And if it is, they get a point. So she got a point for her thigh angle, just barely. The second one is her trunk angle. So we want her trunk to be forward 30 degrees or more from the vertical. So she's at 47 degrees, so she got another point for her trunk. So she's at 2 points there. Then we look at her knee in relationship to her foot. The step down is the one exception where we do let that knee come forward to the toe just a little bit, because the whole point of a step down is to progress forward down the stair. So she is just a little bit in front of her toe, but that's okay for a step down. Typically, we want that knee to be at the toe or back to about the midfoot is kind of that grace period for where we want the knee to be. Otherwise, she would lose a point there. So overall, she got a 4 on her step down out of a possible score of 8 on her step. So then we'll take her through the other 5 skills and put them all in this nice graph. So you can see that it breaks down each of the skills and gives you the score of the individual skill, and then it also shows you how they do on individual components of movement. So you can see that additional component that we measure for more plyometric activities is shock absorption, seeing if they bend into that knee to a sufficient amount. So the athlete and most of the doctors that I work with are only concerned with that total score. So the score is out of 50. So a complete pass would be greater than a 45. That means that they have minimal risk of re-injury. So when I say re-injury, I don't mean that they're just going to tear their ACL again, but injuring the other knee or injuring their ankle or something like that. So just another increased risk of general injury. So greater than a 45 means they have minimal to low risk. 40 to 45 is still a medium or moderate risk of re-injury. And then less than 40 is a high risk for re-injury. So you can see she got a 38. So she's not at a point where we really want her going back to her athletics yet. So that's the score that she's going to take back to her doctor. Now for me as a physical therapist, as well as sports performance coaches, athletic trainers, sports coaches, what's more important than that final score is how they got there. So I look at this graph as my roadmap for what to do next. So this helps the athlete figure out how to get from you're not ready to you're ready. So you can look at individual skills and see which one still needs to be worked on. And you can see for her, it's that step down I showed you. Maybe even more important than that is looking at which components of movement they still need to work on. So for her, she lost 4 points both for pelvic stability and hip strategy. So that tells me that everything that she does and with her sports performance coach, with her physical therapist, needs to challenge those two components so she can start learning, relearning how to move in a way that's going to minimize her injury risk. So everything she needs to do needs to be really focused in on keeping that pelvis stable, getting low into that hip, keeping that knee behind the toe, and those sort of things moving forward. So that leads me right into this. So what I have learned with this is that when you go over these results with your athlete, there's going to be an incredible emotional response. They've already been through an awful lot. Recovering from an ACL injury is emotional, it's challenging, it's difficult, it's all of those things. And then if you sit down and tell them, you know what, you still have some work to do, they're going to be emotional about that. There might be tears, they might get withdrawn, whatever their way of handling it is going to happen. So what I try to do is quickly pivot from you're not ready to here's how you're going to get ready. So I try to quickly say, yeah, you have these issues, but here's how we're going to fix them. I try to quickly empower them and encourage them that now that we know what's wrong, we can really do something about it. To best do that, I need to know who else is part of the decision-making process. I need to know what doctor that I need to send my report to. I need to know if there's a coach or a trainer that I need to be in communication with. And then I need to know who's in their life that's going to help them with this, parents, significant others, etc. I've also learned that I need to be very, very, very clear about what they can and can't do, and especially be very clear about the time frame for that progression. So if you tell somebody, you can go back to practice to build up to play, they very well might go to practice Thursday and play in a game on Friday. So you need to tell them, you need to go to 8 practices, you need to be able to do X, Y, Z before you can play in a game. And that first game is going to be maybe 20 minutes or 10 minutes, whatever you think it is. I also give them 3 to 5 exercises to help the athlete work on those remaining deficits. So even if these exercises are redundant to something that they're already doing, it helps them make that connection between this is what I still need to work on and this is how I'm going to do it. So those exercises will give them an idea of other things that they can do that are focusing on those same problems in this last phase of rehab. So here's my office. So I always bring a table with me wherever I go, just so I know that I'm going to have a workspace to be on. My backpack has a 17-inch laptop. I got some lightweight tripods for the cameras, and I have tape and bands and things like that in there. The Neuraxon bag has all of my straps, my cables for the cameras, as well as extra stickers for EMG units and whatnot. That front left case is my dynamometer. It's a highly calibrated device, so it gets its own case. Then that roller suitcase looking thing is the meat of it. That's the Neuraxon Mobile Lab. So what we have is 2 high-speed cameras. We usually put one in front of the patient or behind them, as well as the other one will be laterally on the side of the injured limb. We have 8 sensors, or half a body. So for her, I had the entire spine, the pelvis, and then both legs through the feet. You can redistribute those sensors in the program and save that configuration to change it for, let's say, a baseball thrower. I'll do, of course, the throwing arm through the spine, the landing leg, and then the stance leg to the foot, things like that. I also have 4 EMG channels. I don't use them so much for my evaluations, but they're an incredibly helpful tool for treatments for those athletes or clients that have a really difficult time either turning a muscle on or turning it off. They can have that external cue on the laptop to see if that EMG signal is going up or going down, how we want it to be. I go to different clinics all over Southern California, and I have slightly different contracts with all of those clinics, but they typically, I'll give them a percentage of what I charge. So that's kind of how my business model works. Most of my referrals come from a kind of equal part physicians, physical therapists, running clubs, gyms, all of those sort of situations kind of come to me. And with this lab, I'm able to work in a variety of environments, seeing a lot of different types of people, and able to be flexible with how I measure it and figuring out ways to really put a number to a movement that might otherwise be difficult to assess. So in conclusion, return to sport tests need to be quantitative. This makes them repeatable. It helps you determine symmetry and sufficiency, and it takes away the emotion from a really emotional decision. So being able to be quantitative gives you power in that decision. It makes the buy-in really huge. The test, of course, needs to be relevant, and again, looking for that symmetry, right versus left. Don't underestimate the importance of discussing the results and expectations with your patient. That's going to be the most important part for them, so don't underestimate that.